Hello viewers, I am Dr. Divya Goel, a neurologist based in Metro Hospital, Faridabad. Today I'll be talking about a very common complaint which we encounter in the neurology OPDs, that is vertigo. In layman term, it's called chakkarana. How do we define it? Vertigo is basically hallucination of motion. This motion can be in the form of rocking sensation, spinning sensation, rotatory sensation or a floating sensation inside the head or in the environment. The foremost thing is to differentiate it from lightheadedness. Lightheadedness occurs when the patient gets up from a supine position and after getting up he has a blackout due to fallen BP and finally he may suffer with fainting or unconsciousness. This is important to differentiate because many a times when patient come to us in OPD, they say डॉक्टर साहब चक्कर आते हैं, BP fall हो जाता है. So you need to understand that an episode of dizziness without fainting comprises vertigo, but with fainting is lightheadedness. Now vertigo basically can be of two types. It is either peripheral or central. Peripheral is when the pathology is localized in the inner ear or the vestibular nerve, and central is when it is localized to the brain. Peripheral vertigo is much more common than the central vertigo and is much less dangerous than the central vertigo too. So there are certain symptoms when we can differentiate with the help of which we can differentiate between peripheral and central vertigo. Peripheral vertigo you see is very abrupt in onset. There are short spells of vertigo. It rarely leads to imbalance but is accompanied with nausea, vomitings, hearing loss and tinnitus, that is ringing sensation in the ears, or sometimes fullness in the ears. On the other hand, central vertigo, this is basically gradual in onset first of all, that is slow in onset. Then it is continuous, there are large spells, and it is not very commonly associated with nausea, vomiting, hearing loss, rather it is associated with brainstem signs. Now how to identify them? There can be slurring of speech, there can be difficulty in swallowing, there can be double vision, people can see two objects instead of one, or there can be numbness in a part of face, then there can be deviation of the angle of mouth, or some body part may go numb or weak. So you need to differentiate them because central vertigo, they carry the red flag sign, and obviously neuroimaging needs to be performed in the form of MRI or CT scan of the brain. So let's first consider what is peripheral vertigo. The most common type of peripheral vertigo is BPPV. Now this is benign paroxysmal positional vertigo. As it sounds a scary term, but I assure you that in the term itself the whole thing is explained. Benign, that means it is not severe. Paroxysmal, that means it occurs in pulses and bouts. Positional, that means vertigo is precipitated in certain head positions. Patients may complain that they have vertigo when they look down or to the right or left, or sometimes while they take turn in bed they experience vertigo. Now the main characteristic of BPPV is it is very short lasting. The vertigo lasts for a few seconds hardly, and it occurs because see, there are certain calcium crystals in the inner ear which basically are dislodged from their usual place into semicircular canals inside the inner ear. Now this inner ear basically it contains three canalicular structures which are called semicircular canals. When these calcium crystals they travel into these canals, there is some stimulation of some receptors which causes this vertiginous sensation. So that leads to BPPV. So how to identify it and how to cure it? It's very easy to identify. There is a simple small OPD test called Dix-Hallpike maneuver which your neurologist or an ENT specialist can perform on you, and it's just a process of 30 to 40 seconds in which we can localize it to which ear it is the pathology is lying, and then we can always perform a canalith repositioning maneuver. Here what you need to remember is that BPPV is a benign condition, though the vertigo is severe and it seems like everything is rotating and you'll fall down. But I assure you, first of all, it is a benign condition. Secondly, The important thing is it doesn't require any treatment with anti-vertiginous drugs. It can be easily controlled with certain neck exercises, certain neck maneuvers, which can be performed easily by a neurologist. Then other causes of peripheral vertigo are vestibular neuritis, labyrinthitis, both of which are mostly due to viral infections of the inner ear. And in this, the vertigo is a bit prolonged. It can last for days to weeks too, and it is usually associated with nausea, vomiting, hearing loss also. Steroids may be helpful in such cases. Then there is one more type, Meniere's disease, in which there is increased pressure in the inner ear fluid, and the clinching feature of this Meniere's disease is that apart from vertigo, it is also characterized by hearing loss, which mostly is unilateral but can be bilateral, and along with that there is ringing in the ears, which we call tinnitus. Then coming on to central vertigo. Now, central vertigo is basically due to pathology of brain, that is cerebellum or brainstem. Now, this is important so that you can consult your neurologist and go in for the CT scan or MRI of the brain to detect or delineate the exact pathology. It can be due to blockage of certain vessels in the brain, this is called stroke. It can be due to demyelinating disease, or it can be due to some infection, or underlying process can be a tumor or mass lesion which is compressing on the brainstem or cerebellum. So accordingly, then we treat the cause and you are freed of vertigo. So these are certain salient features of vertigo, the types, how to identify BPPV, which is the commonest type, and how to actually identify it and consult your ENT surgeon or a neurologist at a specific time. I hope this video helps you. Thank you guys for your patient listening.